the first thing we do is always take these chest tubes and connect them up to the 3-chamber system. And so I think it's an important topic to go over just because the Pleurovac, which is the brand of 3-chamber system we use at our medical center, I refer to as the black box, even though it's a white box, but it feels like a black box because people come into it, take a look at it. They're not really sure what they're supposed to be looking at, but they look at it anyway, and then they walk out of the room. And so I think it's important to decipher the black box a little bit. And so historically, these were 3 chambers, right? And that's why it's called the 3-chamber system. Nowadays, the 3 chambers have been put all together, but the 3 chambers are important to go through. The first chamber is the collection chamber. So that's the chamber that comes off the patient at first. And it's literally just a collection chamber. It's a glorified graduated cylinder, I say. It's really a way for us to measure pleural fluid output per unit time. Less relevant in a discussion of pneumothorax, but certainly important in other patients with a hemothorax or a pleural effusion for some other reason where you really want to get a sense of how much fluid is coming out per hour, per day, or so on. The next step in the 3-chamber system, the second chamber, is the water seal. And so this is an important one because this is the way that we protect patients when they have a chest tube in place. Remember that intrapleural pressure is negative to the ambient environment. And so if you just had a tube coming out from the patient's chest into pleural space, there would be a gradient for air to move into the chest, right? Because pleural pressure is negative. And that would cause you to have a pneumothorax again and defeat the purpose of putting in a chest tube to begin with. And so that's where the water seal comes in. So the water seal is just a thin column of water that is pretty easy for air or fluid or air to displace away from the patient, because away from the patient is really a small column of water, but it's connected by a straw to chamber number 1. So in order for air to move towards the patient would have to suck that fluid from chamber number 2 through that tiny straw and collect it into chamber number 1 to allow a free flow of air coming towards the patient. And that's what the beauty of the water seal. It really only allows air to move in one direction away from the patient. The final chamber is the suction controlled chamber. Actually, before that, I'll go back to chamber number 2 because chamber number 2, the water seal, is where we're going to look for the air leak. So that's really something to keep an eye on when you're examining patients with pneumothorax every day, because that's going to really help you if the air leak persists. But that's where you're looking to see if there's ongoing air moving out of the chest or moving out of the pleural space, which is consistent with an air leak, meaning the hole in the lung hasn't healed yet. The other thing to look at in the water seal is to make sure that there's water in the water seal. In most models of the 3-chamber system now on the market, someone has to put the water into the water seal when they set up Pleurovac. And that usually happens, but not always. Sometimes people forget, or the water may have spilled or evaporated. So it's always good to just do a quick look to make sure that, is there water in the water seal, and are you seeing bubbling to suggest an air leak? The third chamber in the system is the suction controlled chamber. And there are a couple of different sort of versions of suction control in the system. There are wet suction control chambers and dry suction control chambers. Here, most places now have a dry suction control chamber. And what that is essentially, it's a pop-off valve open to the ambient environment that pops off once the system hits a certain pressure. And I'd like to explain the importance of that third chamber by just giving you a hypothetical example in which that chamber didn't exist. So what if we just had chamber number 1 and chamber number 2, and then directly connected chamber number 2, the water seal, up to the wall suction? And most people don't know this, but most times when you're connecting the chest tube to suction, the chest tube or the Pleurovac is set at minus 20 centimeters of water. That's just an arbitrary setting that we set it at. Whereas the wall suction is routinely set at negative 100 or sometimes negative 200, or sometimes it's just cranked to max, depending on whoever's in the room setting it up. And so let's give a hypothetical example in which that suction control chamber didn't exist, and we just connected chamber number 2 directly up to the wall suction, and therefore exerted negative 100 to negative 200 centimeters of water pressure on the chest. And remember that normal pleural pressure is probably about negative 4 or negative 5. So if you were to put someone with a chest tube to negative 100 or negative 200, that's going to be extremely painful and probably pretty dangerous as well, too. It's going to rip open the lung. And so that's where that suction control chamber really comes into handy, because what that is a sort of intermediate step between the water seal and the wall suction. And what it does is you set it some arbitrary pressure. As I said, most of the time it's minus 20 centimeters of water. So the system then says that when I hit negative 20 centimeters of water, I'm going to pop open that valve. And that valve, again, is open to the ambient environment. And it just allows the free flow of air to move into the system to offset any further pressure changes to be applied on the system and then on the chest. So you can crank that wall suction up to negative 2000. And all that's going to do is just increase the gradient for air to move in across that valve that popped open in chamber number 3, just pull more air in from the environment and therefore limit any further pressure to be exerted on the chest. And so this is the modern version of the 3-chamber system that we're talking about before. And I put 2 of the most common versions of this that are out there, at least in my experience, up here so we can take a look at them. And what we have are just the 3 chambers, but now they've been consolidated into this one box. And so the one here on the right is the one that we see most often. It's the sort of the atrium oasis system. And it's a little bit inverted, meaning that air is moving from right to left in this situation. And so here we have the tube coming from the patient's side all the way at the top right of the box. And then it goes through this 3 chambers, and then it gets connected up to wall suction. And the wall suction, this little blue spigot, is where the connection or the hose would be that would then connect up to wall suction. And as you can see, as the first chamber that we encounter from the patient side is the collection chamber. And this is where you see these numbers marking out the pleural fluid volume over unit time. And this is where either you or the nurse or other members of the team would just go in and mark up, a fluid level and then write the date and the time on there so that you can more easily keep track of how much fluid is coming out. But I mean, it is good to take a look at the pleural fluid output because we do want to keep an eye on that. If it starts looking as if it might be getting infected, that's one of the biggest fears for these pleural drains is that the chest tube itself is infected. So if you see the color of the fluid changing, keep an eye on that. If it's normally serous amber color and it's turning cloudier or bloodier, we'd want to know. And so moving again from right to left in this chamber. So the next one we see is the water seal. And that's where you've got air coming from the right side in this situation where the patient side tube is connected to the right. In order for air to move from right to left in this situation, meaning away from the patient, the air from the patient side just needs to displace this tiny little bit of water, these 2 centimeters, before you start seeing bubbling in the water seal, which is where we're monitoring for the air leak. If you take a close look at it, you'll see that there's a little ball in this thin straw-like structure, and you'll see that ball move up and down with the respiratory cycle. And it's almost like a barometer of the pleural space, because as you see that ball move up and down, that's going to be, as I said, in concert with the respiratory cycle, in concert with the wave-like variation in intrapleural pressure as patients breathe in and out. And so you kind of want to just quickly eyeball that to see that it is moving up and down in concert with respiration, because that's called tidaling, right? As the patient's taking tidal breaths, you want to see that communication sort of motion up and down. If you don't see that, that could be an indication that the tube has become obstructed, kinked, or God forbid, accidentally fell out of the patient. And that would be a sort of an emergent situation in the patient with a bad pneumothorax. So you do want to keep an eye on that. The other way to see tidaling, I find oftentimes easier than that, is actually just to take a look at the tube that connects from the patient to the box, this thick silicone-based tube. Because as we said, there's always a little bit of pleural fluid in there. And what you want to see is that with respiration, that pleural fluid is just undulating back and forth with respiratory cycles. And that's another clue that the tube is tidaling and that it's not obstructed or kinked or fell out. Most of the time, you should see it with just regular tidal relaxed breathing. But if you don't, you can ask the patient to do a little bit more of an exaggerated, respiratory maneuver, and that'll help in certain situations where, you're not seeing that. But if a patient's on suction, sometimes that just blunts the entire respiratory cycle because the system is under pressure, and so you may not see tidaling in a system that's on suction. It's also important to keep in mind. The other important thing with chamber number C is to make sure that there's water in the water seal. And it sounds obvious, but unfortunately, mistakes can happen. And if you've never set one of these up before, the water doesn't come automatically in the water seal. There's a little sort of plastic container on the back of the chamber that you rip off and then actually pour the water into the water seal when you're setting up the box at the bedside. We see this about once or twice at our hospital where someone unfortunately forgets to put water into the water seal. Thankfully, the newer tube systems like this one has a couple of safety measures in place to prevent that from being a situation in which air can be entrained to the chest, but those aren't fail-safe either. So it's good thing every day to keep an eye on how much water is in the water seal, make sure that there is some. And the last one, of course, is a suction control. And so here, that's in the top left of this box. And like we said, this is not one of the older versions of the wet suction chambers. This is a dry suction chamber. So there's no fluid in this chamber number 3. Chamber number 3 in this system really just consists of this dial that ranges from -10 all the way up to -40. And there's a little wheel all the way here on the right where you can actually manually control where that dial is set to. Like we said, we arbitrarily usually set that at -20. The other part of chamber number 3 here is this little orange valve. And if you look at this chamber closely on the right side here, right where that orange valve is, you'll see 3 little holes. That's where it's open to the ambient environment. And so when you connect this system up to suction, again, the suction will be connected to this little blue spigot up here to the wall. When you connect this chamber up to suction, the pressure in the system will drop until it hits whatever you set the dial at. Usually it's -20. Once it hits -20, this orange valve will engage, meaning it'll open. It's like an accordion. And once it opens up, it'll then draw in air from the ambient environment and then therefore prevent any further pressure from being exerted on the chest. And this is also something to take a look at, because the way you know that pressure is being exerted on the chest or there's pressure in the system or suction being applied is you want to make sure that this orange valve is visible in this window, that the accordion has come to the right and opened up. If you don't see this orange valve visible in the window, that means that the system is not under suction. And that could be for a variety of reasons. Most commonly, people just haven't turned the wall suction on. And so those are the things that I encourage people to take a look at every day, examine the box with a little bit more sort of attention to patients with pneumothorax.